Hello, everyone. I would like to welcome you to this webinar called How to Handle the Daily Practice Challenges when Prescribing Oral Menopause Hormone Treatment. My name is Dr. Eleni Armeni, and I'm an EMAS board member chairing this session. We will start by giving you some important information around the webinar. You can use the interpretation widget to pick one of the available languages. Languages available are English, Mandarin, Portuguese, Russian, Spanish, and Ukrainian. Your active participation is welcome. You can use the chat for comments and Q&A for queries. The recording will be made available soon online. We are looking forward to our speakers. The first presentation is entitled Most Frequent Challenges and How to Handle Them, and will take place by Dr. Khulood Al Awadi, who is an international representative of the Faculty of Sexual and Reproductive Healthcare of the Royal College of Obstetricians and Gynecologists of the UK, and a leading expert in sexual and reproductive healthcare in UAE, and has also played a crucial role in establishing the specialty and promoting sexual health awareness in the Middle East. Dr. Al Awadi, the setting is yours.
Thank you very much, Dr. Elena. Good afternoon, good evening, everyone, depending on which part of the world you are in. I'll be talking today about the challenges. Can I put my slides? It's sharing, right? You can see my slides?
Yes, we can see your slides. Please start the slideshow from beginning. If you click in the first icon on the top, so that we can see your slides in full. Exactly.
Yeah.
Thank you so much.
So I'll be talking about most frequent challenges when prescribing oral menopause hormonal therapy in the United Arab Emirates and how to handle. So I have no conflict of interest in relation to this presentation. I've grouped the challenges that we face into three categories: patients, treatment, and healthcare professionals. With regard to patients, there are limited awareness and education among our patients in the United Arab Emirates. They don't know about, many of them, they don't know about menopause. They don't know about the symptoms of menopause. And if they know about menopause and the available treatment, they are hesitant to take it, and concerned about the side effects, about the risk factors such as breast cancer risk and other cancer risks. So there was a couple of studies which I came across. One of them, it's a cross-sectional study which was conducted in the year 2020. It's about Emirati women's knowledge about the menopause and menopausal hormonal therapy. It was published in the International Journal of Environmental Research and Public Health. It was conducted on 497 Emirati women visiting 5 primary healthcare centers in Dubai. The data were collected using a questionnaire composed of socio-demographic and reproductive characteristics, menopause knowledge scale, and menopause symptoms knowledge, and hormonal therapy practice. This table presents the percentage of participants who agreed to individual items on their menopause and menopause hormonal therapy knowledge scale. So if you can see here in the agreement percentage, 67% agreed that menopause is due to decrease of female hormones. And 59.4% agreed that menopause is accompanied by hot flashes. While if you see down here, only 24.9% thought that menopause hormonal therapy improves hot flashes. And 29.6% thought that menopause hormonal therapy has many complications, and side effects. So you can find out from this table the level of knowledge and the acceptance of medication. The result of this study showed that mean menopause symptoms knowledge percentage was only 41%. And there were significant difference among those educated and those who are employed. And there was no significant differences in the knowledge percentage among categories of menopausal state. Whether you are at high education level, low education level, the knowledge were the same. And it was very low. There was another study which was conducted in 2021. It was published in PubMed, and it showed that the percentage of women who had fair to poor overall knowledge and menopause were very low, which agrees with the first survey, which was done in 2020. Going forward, other challenges with regard to the patient, comorbid conditions. Patients may have comorbidities, hypertension, diabetes, and they will think that, okay, because I have hypertension, I cannot take menopausal hormone therapy. The other challenge, monitoring and follow-up. People will not, most of the patients will not come for the follow-up. They will be ignorant. They will have other things to do. And cultural taboos surrounding menopause in the country, which can make patients not come forward to seek treatment, and which will affect their willingness to seek help or information. With regard to the treatment, access and cost issue. In the United Arab Emirates, we have insurance. So every local and resident, they have to have insurance provided by the government or by their employers, which will cover their medication. If you don't have insurance, then it will be on self-pay basis. And some of them who doesn't have visa, they will come and to seek only medical advice, and then they have to pay for everything, which will put them from coming forward. The other thing, the duration of therapy. For us to determine how long to continue menopause hormonal therapy, and for the patient to accept this, sometimes it's challenging. Managing side effects. Patient may experience side effects such as bloating, breast tenderness, or mood changes, and this can put them from continuing the menopause hormonal therapy. Risk-benefit analysis. This can be particularly complex given the varying risk profiles of patients. With regard to the healthcare professional, many healthcare professionals, unfortunately, some of them are obstetrician and gynecologists in the country, they are unaware with the benefits of menopausal hormonal therapy. And I have many patients who come to my clinic presenting with, no, it will give us cancer, we shouldn't take them. The other thing, lack of research and data. We know that menopause among Emirati women is, the average age of menopause is 48, which is much lower than the counterpart patients in the European countries, in the Western countries. But still, we don't have research to address these issues and the uptake of patients with menopausal hormonal therapy and their acceptance. Busy clinics. I work in both Abu Dhabi and Dubai, so I work in government hospital in Abu Dhabi, and I do a private clinic once a week in Dubai. And my clinics in the government hospital is quite busy. I see like 20 to 30 patients a day in 8 hours time. So you can imagine how much time I can offer the patient. So what I tend to do that, I'll talk about this later, that I give them a slot for the next appointment. We'll talk about this later. The other thing we have in the United Arab Emirates wellness program, but unfortunately it does not address menopausal health issues and menopausal hormone therapy. So how to handle these issues with regards, with regard to the limited awareness and education among patients, we introduced public awareness campaigns. We do something called many medical schools. So we go to the communities, to the community events, and provide information and resources on menopause and talk to them about menopause hormonal therapy. In the media, we utilize the social media, television, and radio to spread this awareness about menopause, symptoms, and management options. Also, we talk to the primary healthcare physicians. So I work in a tertiary center, in tertiary hospital in Abu Dhabi. So we get referral from all the primary healthcare professionals. They refer their patients to us to talk to them about menopause and menopausal treatment. With regard to the patient hesitation and concern, we provide clear evidence and based information. We give them leaflets, brochures, and talk to them about it, and call them back to answer their questions and encourage open discussions and address specific concerns. With regard to comorbid conditions, we evaluate the risk and benefits of menopausal hormone therapy in the context of each patient's overall health. We discuss with them and show them the evidence for what we are saying, so they will be convinced and satisfied in starting the medication first of all, and then continuing that medication. And we collaborate with other specialists if necessary from other fields to ensure a comprehensive approach. Monitoring and follow-up, what we tend to do in our clinics, we give them a follow-up appointment just before 3 months' time after prescribing the menopause hormonal therapy, and then annually after that. And the patients we offer them teleconsultation or to make another appointment in between if they have any problem or they want to answer concerns, questions, they are welcome to do so. With regard to cultural sensitivity and cultural taboos, we understand that we have to be sensitive in discussing with patients regarding menopause, its symptoms, and menopausal hormonal therapy. Just before going further, in my gathering with patients with the different situations, I see many patients complaining of hot flashes, and they don't know that this can be treated, and this is a menopausal symptoms, and the treatment is available. With regard to access and cost issues, we are familiar with the insurance coverage, and we tend to talk to patients about it, and we try to ensure that for those who doesn't have insurance, that they have assistance programs to make the medication available to them, and try to work with them and to find cost-effective solutions. For the duration of therapy, we discussed the rationale for duration of therapy and why they have to take for such a duration, and we usually recommend the lowest effective dose for the shortest duration necessary. And we reevaluate that periodically. For the side effects, we tend to, when I prescribe the medication for the patient, we tend to talk to them about the side effects upfront and set realistic expectations. I usually tell them, do not judge the medication before 3 months. And if they have any side effects such as bloating, breast tenderness, we try to adjust the dose or switch to different type of progesterone, which can help them with the side effects. Risk-benefit analysis, we balance the benefits of symptom relief against potential risks such as cardiovascular risk, breast cancer, thromboembolic events. For the healthcare professional, we engage in continuous medical education, especially for the primary healthcare physician, or the other obs and gynae physician, through workshops, online courses, professional organizations, to stay current and best practice. And we do also guidelines and spread them to other institutes within the same government hospitals and clinics. To follow that guideline with regard to menopausal hormone therapy. And we collaborate with universities to conduct research on menopause, specific issues focusing on local populations, and conduct surveys to gather data on women's experience with menopause symptoms and healthcare access. With the busy clinics, as I mentioned, our clinics are quite busy and we see many patients during the day, and many of them are new patients with many complications because it's a referral center. So what I tend to do, give them leaflets and talk to them in general, and put another visit in a 1 week time with more time, like for 30 minutes, so we can discuss their questions and discuss their concerns to increase their satisfaction and increase the uptake of menopausal hormone therapy. The other thing that we are working on to include the menopause health issues with the wellness program. We have a very good wellness program called Inaya. We are trying to incorporate this menopausal health issues into that wellness program. We try to talk to the primary health care physicians who are responsible for these wellness programs, who address the menopausal health and refer the patients to this. So in conclusion, healthcare professionals should address the challenges proactively and empathetically to improve patient satisfaction and outcomes in menopausal hormonal therapy. And navigating these challenges requires a thoughtful patient-centered approach, effective communication, and ongoing education for both providers and patients. What I've noticed that once patients, they know about menopausal symptoms, and they understand that there is treatment, and they understand that this treatment, they understand upfront the side effects of that treatment and the advantages of taking that treatment, they are very much agreeing on starting the medication and then continuing this medication. Thank you.
Thank you very much, Dr. Al Awadi, for this nice presentation. We will move on to the next presenter, which is Associate Professor Dr. Naoual Merrouche Slimani, who will speak about optimizing clinical results, considering the window of opportunity. Dr. Naoual is a professor of obstetrics and gynecology at the University of Algeria. She is also the head of the obstetrics and gynecology department at the Relative Hospital in Zeralda. Before we go into the next presentation, I would like to invite once again the audience to send your questions to our expert presenters using the Q&A. Dr. Naoual, we're looking forward to your presentation.
Good morning. Thank you, Elena. Good morning. Welcome to all of you. I wish to thank you for attending this presentation today. As the first doctor said, in our community, the prescription of the hormonal therapy is very difficult because there is a lot of taboo about this therapy, and also the physician don't propose this therapy for the women. Even they have a lot of symptoms, a lot of vasomotor symptoms, a lot of genitalium symptoms. But after the result of WHE, the study, all of gynecologists stopped propose this hormonotherapy for women. And because also the physician don't have a lot of knowledge about the side effects and the disorders effects after the hormonal therapy. And we will talk today about the optimizing clinical results considering the window of opportunity. The term of window of opportunity in the next of menopause and the menopausal hormone therapy refers to the optimal period during which initiation of menopause hormonal therapy may have the most favorable effect on women's health, including heart health and cognitive function, without new disorders. The most important side effect of the hormonal therapy was the incidence of cardiovascular diseases. But the incidence of these diseases in women is both associated and age-specific, as reported from the Framingham study. In addition to an increase in cardiovascular diseases incident by age in women, postmenopausal women have to six-fold greater incidence of cardiovascular diseases than premenopausal women across the age range under 54 years. And the development of substantial cardiovascular diseases risk after menopause provides a window of opportunity for extension of cardioprotection from endogenous estrogen in postmenopausal women with hormone replacement therapy. And the most important side effect of this hormonal therapy is the increased risk of cardiovascular diseases. But we are noted in a group receiving the estrogen and progesterone in the WHE and HERS trial study. But in the two study HEPAT and WALHEART, we noticed that the effect of on the atherosclerosis progression in postmenopausal women without and with pre-existing clinical vascular diseases is different. There is a reduction in the progression of early subclinical atherosclerosis when the atherosclerosis is not clinical, but when the lesion is symptomatic with pre-existing coronary artery diseases, there is no effect. The initiation of hormone replacement therapy early and continued while endometrium is intact maintains vascular health and reduce vascular aging and progression of atherosclerosis. On the other hand, the hormonal therapy initiated during late-stage atherosclerosis has no effect on established vascular diseases. There is no secondary prevent. Salpeter, in the meta-analysis of Salpeter, he showed that initiation of hormone replacement therapy in women less than 60 years of age and all less than 10 years since menopause is statistically significantly reduced both all cause of mortality and coronary heart diseases relative to placebo. Also the Cochrane meta-analysis validated this conclusion. and this show the windows of activity, of clinical activity. Cervical curve from the Danish osteoporosis study showing statistically significant reduction of cardiovascular diseases by 52% after 10 years of randomized hormone replacement therapy, and relative to no hormonal therapy, and a reduction by 39% after 16 years of total follow-up. Women in DOPS were on average 50 years of age and 7 months past menopause, with an average of BMI, average BMI of 25 when randomized to hormonal therapy or no hormonal therapy. And we noticed that the nefast effect of the coronary diseases, heart diseases, and the mortality is when the hormonal therapy is introduced after 10 years since the menopause or after the age of 60 years. The total mortality, all of the studies proved that when the hormonal therapy is introduced before 60 years or age 60 years or before 10 years since the menopause, there is a diminution of a reduction of mortality of all causes of mortality and coronary diseases mortality. When we studied the age group under 60 years during randomization in the WHI, whether with estrogen alone or estrogen combined with progestin, overall mortality from cardiovascular pathology or from cancer is reduced. This confirms the theory of the window of opportunity. The early versus late interventional trial with estradiol was specifically designed to test the hormone replacement therapy timing hypothesis comparing oral estradiol with or without vaginal progesterone with placebo into strata of women who were at the time of randomization under 6 years since menopause or over 10 years since menopause. After median of 5 years, we noticed that there is a reduction statistically significant in progression of subclinical atherosclerosis measured by carotid artery intima media thickness with hormone replacement therapy. Among women in the late post-menopause, rate of atherosclerosis progression were similar in the hormone replacement therapy and placebo. The effect of hormone replacement therapy on subclinical atherosclerosis progression significantly different between the early postmenopause stratum and the late postmenopause stratum. The global mortality, the Bayesian meta-analysis of 19 randomized controlled trials and 8 prospective observational studies showing the consistency of reduction of all cause of mortality between both study types in women who initiate hormone replacement therapy before age 60 years with 5 years follow-up. How about the quality of life? The global effect of the hormonal therapy on the woman's body systems, reducing menopausal symptoms and increasing the quality of life, in addition to improvement on muscle parameters. Results were significant only for those starting hormonal therapy under 5 years after menopause, which support the consensus of a window of opportunity for hormonal therapy. For the cognitive function, the benefits of hormonal therapy on cognition in women with dementia are similar to the observed in the middle-aged, recently menopausal woman. The benefits were only seen for a couple of months of treatment. In older women after 65 years, at risk for cardiovascular diseases, an increased risk of dementia was seen with combination hormonal therapy used already after 1 year of treatment in WFH. Hormonal therapy possibly increases the risk of cognitive impairment through CVD risk factors pathways, and WFH also showed an increased risk for cardiovascular diseases with hormonal therapy use. The window of opportunity theory suggests that taking hormonal therapy around the age of menopause carries some benefit or at least little risk for cognitive impairment, perhaps for up to 10 years of treatment. Harm to brain function, if seen away, occur in older women at risk for CVD and AD or with longer duration, superior 10 years of hormonal therapy. This potential harm may depend on the type of progesterone used for combination therapy. Hormone use and moods. The study keeps beneficial effect of 48 months treatment with conjugated estrogen, but not transdermal estrogen were observed in reducing anxiety and depression, but just for few months. Most guidelines do not suggest giving hormonal therapy as first-line treatment for mental health disorders, but in additional with antidepressants. Hormonal therapy has proven to be effective in reducing the risk of hip, vertebral, and total fractures. However, this protection is attenuated when hormonal therapy is discontinued or begun after the age of 60. Estrogen therapy is preferred choice compared to bone-specific treatment for a woman with premature menopause, which is related to increased fracture risk. The combined use of hormonal therapy and calcium plus vitamin D supplement has a synergic effect on reducing high fractures. For the vasomotor symptoms, over 32 randomized placebo-controlled trials currently recommended hormonal therapy as a treatment for vasomotor symptoms. Vasomotor disorders are mainly present around the onset of menopause. The indication of hormonal therapy is early. Both oral and transdermal estrogen have been found to be clinically effective KIPS trial. Genitourinary syndrome of menopause and vulvovaginal atrophy. For these part of symptoms in menopause, the vaginal estrogen is the gold standard of therapy, but the systemic estrogen therapy is effective as treating concurrent symptoms, and it is approved or recommended for women with this symptom, as well as vasomotor symptoms, but it isn't the first therapy. For the breast cancer, the risk of breast cancer is the side that which stopped the prescription of the hormonal therapy in our country after the result of WBHI. But actually, we know that the hormonal therapy for longer than 5 years was significantly related to an increased incidence of breast cancer in patients age between 50 and 69. In conclusion, the majority of the guidelines and the scientific society agree that the indication of the hormonal therapy are menopausal symptoms, not to prevent cardiovascular diseases or bones diseases. And one of the indications also is the primary ovarian insufficiency or the early menopause. What is important is the initiation of this therapy. It must be under the age of 16 years and within 10 years of the onset of menopause, and which is very important. And this is the windows of opportunity to improve the effect of the hormonal therapy, and without improving the side effect of the cardiovascular diseases, of the mortality of the breast cancer, is to prescribe this hormonal therapy for a duration of only 5 years or less. Thanks for your attention.
Thank you very much to both of our speakers for these excellent presentations. With regards to questions, we have one at the moment at the Q&A, so I would like to invite all of you once again to try and challenge our speakers with regards to interesting facts. The question is breast cancer risk related to both oral and transdermal use of HRT? I would like to invite both of our speakers, but particularly Dr. Naoual, because this is a little bit closer related to her topic, to answer this question.
The breast cancer risk related essentially for the duration of the hormonal therapy. Even the both oral or transdermal use of the hormonal therapy, when the duration is longer than 5 years or when it is introduced after 6 years, 60 years old, it will be increased. It can be increased.
Thank you very much.
Can I add something?
Yes, definitely.
Yeah. Also the study suggested that those estrogen progesterone combined hormonal therapy, menopausal hormonal therapy, those which having micronized progesterone or dry progesterone has lower risk of breast cancer. And in addition to the duration of use.
Perfect. I presume that both of you are giving the individualized advice to the women that are visiting you in the clinic in order how to choose the most appropriate regimen based on the underlying level of their own risk with regards to breast cancer. Moving on to another question. The question is, how do you manage patients who are skeptical towards hormonal products and hesitate to take menopause hormone therapy? I would like to invite both of the speakers who represent different parts of the world to describe their own experience. Thank you.
Okay, in the United Arab Emirates, we come across this many times. Actually, most of our patients are hesitant to get the menopausal hormonal therapy. What I tend to do in my clinic, I talk to them and show them actually in the pull out the evidence on my computer and show it to them and give them some leaflets and brochures and some websites that we were using in the UK and tell them go and read about it. I discuss with them and tell them go and read about it and give them another follow-up appointment in 1 week time. Okay, to discuss their questions and answer them. And I've seen from this approach that many patients are taking the menopausal hormonal therapy, and it's changing actually. And after starting the medication, they are coming back to me very happy and wanting to continue it.
Dr. Naoual?
Yes, in our country, most of our women don't want to take hormonal therapy, even that they have a lot of symptoms, and how to say, to convince her to take this therapy, we must talk with her a lot. We spent with her a lot of time to explain her the benefits with therapy, and also we told her that there is not a lot of side effect when she take just 1 or 2 years of this therapy.
Thank you very much. The next question I would like to address to our speakers is, what is a low dose locally administered for genitourinary syndrome? Is it also given for maximum of 10 years and before the age of 60? There is a follow-up question to this, but let's start with the low dose.
Yeah.
Dr. Naoual?
For the low dose, just we give a cream, just a cream of local estrogen once a day, but we for the genitourinary symptoms, we don't have to introduce this therapeutic before 60 years. We can use it after 60 years, after 10 years since menopause. It's not a problem, and we can also give this therapy for a long time, because when we stop the therapy, a few months after, the woman will have her symptoms.
Thank you very much. And please, for Dr. Al Awadi to help us clarify for our audience, should menopause hormone treatment be stopped after the age of 65, or rather continue? We have spoken already about what to do with regards to the genitourinary syndrome of menopause, but what about the general menopause hormone treatment? Should we stop it at the age of 65?
We stop by the age of 60, except if there is like, we have to take it again as on an individual basis, but usually we don't continue the menopausal hormonal therapy after the age of 60. Depends, we have to, depends on the patient herself, but in general, yes, we don't continue after the age of 60.
And a question from myself now, what would you advise to your women if they want to continue on menopause hormone therapy and they have low risk for cardiovascular disease or breast cancer at the age of 61, 62, yet again, they have a high prevalence, high risk, high bothersome vasomotor symptoms?
Bothersome, yeah. So again, it is an individualized choice. It depends on the patient. So if they have menopausal symptoms and they are low risk, of course, we'll give them the menopausal hormonal therapy. We have to balance the benefits and risk for each patient and individualize the treatment for them.
Thank you very much. One more question is related again with the breast tumors. The question is asking us to whether or not there is evidence with regards to a high risk for benign breast tumors after the use of menopause hormone treatment. I presume systemic menopause hormone treatment is what the question is implying. Do both of our presenters want to engage to deal with this question?
With the risk of benign, or because the menopausal hormonal therapy does not increase the risk of benign tumor, as far as I know. It increases the risk of invasive cancer, breast cancer, if it is used more than 5 years, the duration of the use. But in general, it does not increase the mortality from the breast cancer, even after 5 years.
Dr. Naoual, is your practice similar?
Yes, there is not the hormonal therapy don't increase the benign breast tumor. There is an increased risk of breast cancer, and in the WHE the problem was with the progesterone, because they use it the medroxyprogesterone, and with this one perhaps the problem was with this progesterone, not with the others.
Thank you very much. I found one more interesting question in the chat. The question is, can we give HRT to all menopausal women routinely? What is your practice locally? What about Dr. Naoual to start, please?
I didn't hear you. Can you repeat?
Can we give HRT to all menopausal women routinely?
No, no. As I said, all of guidelines. As I said, all of guidelines said that we give hormonal therapy only to women with insufficiency ovarian, premature insufficiency ovarian, and precoce menopause, and for the woman who has a lot of symptoms like vasomotor symptoms, like especially the vasomotor one, but not for all women.
What we tend to do in our practice depends again with the patient. So if she's within the 10 years of menopause and below the age of 60, and she has, I take detailed history because my specialty sexual reproductive health is not only the vasomotors that I talk about. I talk about sexual activity, vaginal dryness, urinary incontinence, mild urinary incontinence, and other aspects of symptoms in life. So I take low threshold and prescribing menopausal hormonal therapy for this category of patients. And discuss with them regarding risks and benefits, and we take a mutual decision between myself and the patient, and then decide accordingly.
Makes sense, of course. I would like to invite both of you again to address the next question. What do you do locally? When stopping menopause hormone therapy, would you down titrate or just stop abruptly, please? Dr. Khulood?
Yeah, we titrate actually. I don't stop just at once, and talk to them, discuss with them. I always discuss every step of management with the patient, and take her on board with me with the decision. So usually we titrate before stopping, and see how she is doing while we are reducing the dose. Is there symptoms which appearing? Is how she's doing in her life, and then I'll call her back and see, and then stop gradually.
Thank you. Dr. Naoual?
When the patient must stop her therapy, I stop it, and I look for their symptoms. If she have a lot of symptoms, and if she don't have yet 60 years old, I can give it to her few months after.
Thank you very much. I cannot see further questions from the audience yet, so I would like to ask both of you if you faced any difficulties in trying to engage primary care practitioners to help monitoring and prescribing with you, next to you, hormone replacement therapy for women in menopause.
Okay, in my country, it is difficult to do that because the medication is available only in the menopause in the hospital, in tertiary hospital. So they have to refer the patient to us. That's one point. The other point, the level of knowledge among the primary healthcare physician and some obs and gynae physician regarding menopause and prescribing menopausal hormonal therapy is getting better now, of course, with the workshop, with everything, but still there are, I get now and then few patients coming, no, the doctor told us you cannot use this, it will cause you cancer. So it's in the pipeline, but still we are working on that.
Very good.
We have to provide the medication. We have to provide make the medication available everywhere. Like in Abu Dhabi, we have the medication. In Dubai, still we don't have the medication even for the menopause centers.
It's interesting to see what is out there in any case.
In our country, we don't have all of medication about the menopause. That is the first problem. And the second one is the knowledge of the physician. There isn't updates about the risk of menopause and of the hormonal therapy. The majority of the physician are very skeptic about the prescription of the hormonal therapy because of the risk of breast cancer, and improving their knowledge is the most important thing. The most important thing.
Very good. And then one more question, if any one of you or both of you want to address your experience and your preference perhaps when it comes to Tibolon. Are you using Tibolon in the daily practice?
We don't have it, unfortunately, yet so we don't have this option.
We don't have it also. We don't have Tibolon. We had it 10 years before, but after the study of WFH, we don't have it.
Interesting. One more question. Can you please give some examples of combinations of estradiol and progesterone with doses as hormone replacement therapy?
Fimostone, we have Fimostone. I'll tell you what's available in the country. We have Fimostone, we have Conti and Sequi, both we have. It's just being introduced in the country. We have patches, but only in Abu Dhabi. We don't have it in Dubai. Overall Conti patches. We don't have the Sequi. We have estradiol patches alone. And then so we combine the estradiol patches for those whom I want to give Sequi. I'll give them estradiol patches and overall Conti. So, and I tell them how to use it. So that's what's available to us. And of course, we have Progylaton, which is quite an old one.
In our country, we don't have a lot of choice. We just have Climaston, and we have Progenova and progesterone, but we don't have a patch. We don't have transdermic estrogen. We don't have it.
Very interesting. And we have some more comments on Tibolon, but this is not, if this is not available, I will not expand on Tibolon. I wanted to ask, I understood from Dr. Al Awadi, you're doing great educational effort in order to explain to the women what is menopause and what they can face, what they should expect. I'm sure something similar is taking place locally for you, Dr. Naoual. Do you think there is room for further education, or the problem has to a good extent been solved by now?
No, definitely. There's a big room for more education, because every time you will face some patients and some healthcare professional who is not up to date with the evidence, and still having the fear of starting it and continuing it for a few years. So yes, of course, there is always room for more education, and we keep continuing and doing workshops and doing presentations and media and things like that to increase the uptake and increase the awareness. Even in my social life gathering, I've came across many patients or many friends who are complaining of menopausal symptoms, and they are educated, but they didn't know that this can be treated, and this is because of menopause, which is unfortunate. But yes, I think we still have to we are at the beginning of the road to increase the awareness with regard to menopause and their treatment.
Thank you very much, and thank you for your efforts. Dr. Naoual?
Yes, I agree. We must improve the knowledge of our physician, but also we have to educate our women, because in our country, to have the symptoms of menopause is normal, and the woman don't go to the physician for the symptoms. For her, it's normal, and it will pass after a few years, and it's not need prescription, and she don't want to improve her health care because of the risk of the risk cancer, because there was a lot of discussion about these risks in the social media.
Of course, this is everywhere the case, but education is still needed for everyone. I will continue with one more point made in the Q&A section, where one of the colleagues from the audience wants to remind us about the fact that the risk for breast cancer is related with many factors. Hormone replacement therapy is not obviously the only one, and that is something worthy of being addressed during the consultations. Smoking and being overweight is one group of factors. Healthy lifestyle or even genetic risk and gynecological factors can also contribute to the individual risk of breast cancer. So I want to ask both of our presenters, do you do an extensive evaluation for the breast cancer risk before you prescribe menopause hormone therapy, taking all of the risk factors into consideration, or just a rough assessment of the risk factors?
No, we do a detailed risk assessment for all the patients who are coming to us. We are, as I mentioned, we are tertiary units. So many of the patients, they had all the history and everything was taken and questioned in the notes before, but then we built on that. yes, every patient will do the risk assessment before prescribing any hormonal treatments.
Perfect. What about you, Dave?
Sorry, we are in the process of providing like a sheet for the patient to fill it up before coming to our clinic. So that's that's in the pipeline.
Very nice. Dr. Naoual?
Yes, for us it's true because in our country we prescribe mammography systematically after 40 years, and for this if the most important women who need hormonal therapy is after 40 years old, after 40 years, and they have their mammography. We evaluate the risk of breast cancer, and there is another problem in our country is the BMI. There is a lot of high BMI and insulin resistance, and we don't have a lot of smoking, but a lot of insulin resistance and a lot of diabetes, and it's also a risk of breast cancer. And breast cancer is the first cancer for women in our country, and for this we evaluate really this risk before prescribing hormonal therapy.
Thank you very much, both of you, for very interesting insights, and thank you for your efforts in expanding education on the management of menopause in your countries, but also internationally. I think we have reached the end of this session. So I would like to close the session, thanking you once again for being here with us, and also many thanks to a lovely audience. You can find this session recorded online for anyone who is interested to go through the presentations again. And have a nice day.
Thank you. Thanks.